Thank you, Dr. Shyam and Dr. Kaul and Dr. Arvind for having me here. So I'm going to talk about HER2 positive breast cancer therapy and a surgeon's perspective. In one line, the surgeon's perspective is that de-escalate surgery and escalate chemotherapy and systemic therapy. So that is a one-line answer. But I think we'll learn through next 10 minutes that why it is so. So actually it is all this for larger good, for the patient's good, and also to help the patient get the best possible outcome. And this will cover through what is now routine practice. How do we select our patients? What is multidisciplinary teamwork is very critical. Without that, you don't achieve the best results. And neoadjuvant therapy selection, surgical management, both the primary, the breast conservation, and axillary de-escalation, and the response at adjuvant therapy. So this, I think, is today the gold standard, that anything which is T2 or upwards or T1 node positive. And when I say node positive, it implies actually ultrasound guided FNA from the node. So most of our patients would have, even if they have a MR or whatever, we always do a sample and node biopsy. And only then we take a call that this is node positive. And all T2 upwards and node positive will get neoadjuvant therapy. Those who are node negative and T1 will go for upfront surgery. And as you see in this, if you have go for surgery upfront, then in that case, if it is node negative, then systemic therapy as written here, Herceptin and paclitaxel. If node positive, then pertuzumab and trastuzumab plus base therapy. And if it is neoadjuvant therapy, then we look at residual disease and take a call for the selection of systemic therapy. Now, this is the residual therapy. This is the part which is important. That is why neoadjuvant therapy is critical and should be integrated. I'll skip this slide because, or I'll rather share, because medical oncologists, just to get a perspective, that surgery for breast includes mastectomy or conservation and reconstructions. All this is possible today, conservation or nipple sparing mastectomy, all this is possible. And the only point I would want to make here is that post NACT breast conservation rates go up. I'll show this subsequently also. And that is one big advantage, or rather, that is one area which today's patient population is selecting more and more. So because I have the advantage of almost 30 years of practice, I can say that initially there was no thought given to among the choice of surgery. It was dominantly discussed by patients and families that go for mastectomy. Today they spend hours and do their homework, how we can conserve the breast. So this is a huge shift which we are seeing, and I think it's because the results are same, it's definitely a very good thing to happen. Now, what does neoadjuvant therapy offer in the management of early breast cancer? So it enables response assessment. That is what pathological CR, or is they achieved or not achieved. That is one important thing. So in vivo assessment to response provides an opportunity to adjust adjuvant therapy accordingly, because once you have a pathological CR, the treatment plan changes. Enhances surgical options. As I said, downstaging of the primary leads to higher rates of breast conservation. The important thing is downstaging of the axilla also. So downstaging of axilla is an important data which has come up. And in fact, now there are trials going on how to get axillary surgery out of the domain of the surgeons. And if we are getting a good response, we can even treat by radiation. And that also will be briefly discussed, and allows planning for reconstruction. And as Randeep mentioned, even we get data of the genetic study and further, and that also you get time for that, and allows early treatment of micromets. So this is an important thing which I drive towards surgeons when I say that whenever there's a doubt, start with neoadjuvant therapy. And the reason for that is that more patients you lose to systemic disease than to local disease. So if there's a doubt, don't hesitate. If the patient has to have chemo, then better to start with chemo, and that's not a bad choice. So this is how we run our MDTs. The only person who is missing in this list is the radiation oncologist. So I think next time we should have that also in the MDT group mentioned. Otherwise, pathology, radiology, everybody has to be part of it. And once it is discussed, then we take a plan. Now, these are the current recommendations of pertuzumab, trastuzumab is recommended for neoadjuvant therapy in patients, as we just mentioned, that all T2 or node positive is the group as NCCN says, and similar thing is by St. Gallen. And however, in ESMO is a dual blockade for all concerned high risk patients, again node positive and ER negative. So typically that is a large concern. Only the AGO says that in all groups, wherever chemotherapy is indicated, start with systemic therapy. That is their mandate. Otherwise, it's all T2 upwards or node positive. Now, these are this is just to highlight that how trastuzumab, addition of pertuzumab has made a difference in the response rates, the pathological CR rates, and you see that this jumps from almost 38-39% to 55% plus. So that is where the impact on survival will be seen gradually, and this is what is the expectation. Now, coming to the question of whether downsizing is safe, whether the patient can be offered conservation, I think this question has been answered long back. We have been doing breast conservation for decades now, and it is standard of care that you don't go for initial tumor size, you go for residual tumor size. That is where the opportunity lies in getting good cosmetic results and good outcomes in conservation. And, and this is proven beyond doubt that this is of equal results as far as the recurrence rates are concerned. What about locally advanced, where the skin is involved, whether it is inflammatory or T4B disease? There, I would say in inflammatory breast cancer, I would not encourage surgeons to opt for this unless unless more data emerges. As far as T4B is concerned, there's wherever there's mild PUD orange and the area has responded very well. These patients, we have started opting for conservative surgeries gradually. So the uptake on these areas is a bit cautious, but gradually we go there and consider that. So to measure, so look at this whole thing in terms of data, we see that the breast conservation rates go up anything from 8% to 12% different studies if you have started with neoadjuvant therapy compared to people who have adjuvant therapy and upfront breast conservation. Now, as far as the axilla is concerned, today almost all N2 disease and upwards, we offer axillary dissection for all these patients. Though we do find, and this year we have given one of our DNB students a thesis topic of targeted axillary dissection. And the purpose is this only, that we want to adopt this in practice. So we will be clipping the axillary node, positive node, but only for N1 disease, that is less than 4 nodes. So this will be picked up on MRI and ultrasound. However, in this study, they have depended on the PET-CT, but I think the MR and ultrasound are more reliable than PET-CT. And once you have done that target therapy and you have got a magnetic radioiodide targeting of the axilla, then in this study, they have shown that just removing the targeted node is just good enough, and they're going for adjuvant radiation therapy. That means further de-escalating axillary surgery, not just depending on the node positivity. Even if the node is positive, they go for only axillary radiation therapy and not completion of the axilla. However, in the last term, where there is a residual disease upfront, there they have considered both ALND and axillary radiation therapy, which is a bit surprising because wherever you do axillary dissection, there is no need for axillary adjuvant radiation therapy. Now, patients receiving neoadjuvant therapy have improved event-free survival compared to those treated with neoadjuvant trastuzumab only. That is, both who have both trastuzumab and pertuzumab. This is very well proven right in the beginning. We have discussed this, that all these patients have better response rates and therefore better event-free survivals. And this data is also quite significant, that how with event in the, so even in the patients who have trastuzumab only, there the event-free survival, patients with events are 30%, and this drops down to 18% in those who have pertuzumab and trastuzumab, both. And likewise in this study also, this events drop down significantly. So basically highlighting that more and more patients are surviving and doing better, and that is why this adoption in the trials and setting for pathological complete response is giving us good direction. So guidelines again for continuation of pertuzumab and trastuzumab in adjuvant setting is also something which is important, and we see that pathological CR rate guides us whether to use for TDM1 if there's no preoperative therapy or if pathological CR is achieved. Otherwise, in all other situations, we are giving, if pathological CR is complete, then HER2 target therapy is given by ESMO guidelines, trastuzumab and pertuzumab, in case initially node positive or hormone receptor positive, and those by St. Gallen, adjuvant trastuzumab and trastuzumab as originally offered in patients with initial adjuvant systemic treatment regimen. So the basic idea is that all these patients, except for those who have no preoperative therapy, or if TDM1 is discontinued in the event of toxicity, they have to complete HER2 target therapy in all these patients. So in nutshell, I would say that MDTs are directing us to achieve better and better planning for all T2 and node positive disease in terms of adoption of neoadjuvant therapy, and the risk of recurrence is reduced in this subset of patients. So this is the neoadjuvant therapy of HER2 positive patients, early breast cancer. Now, early breast cancer here, I don't know how we'll call it early, because once you're labeling it T2 and upwards and HER2, their adverse factors are coming into play. And therefore, gradually this group will shift towards the not so early group. And surgery is both de-escalated, both for the axilla and also for the primary site. So, the breast conservation rates are down, the axillary dissection rates are down, and we have target therapy, sentinel node, all this will come into play. And adjuvant therapy subsequently will depend on the pathological response rates, where you have pathological complete response. There is with de-escalation, adjuvant treatment decisions should be based on neoadjuvant response, and patients with low risk and HER2 positive early breast cancer de-escalate adjuvant therapy depending on the pathological CR. So that is basically the crux, that these patients should continue either with pertuzumab and trastuzumab or TDM1 in those who are positive with residual disease. That is to improve the overall outcome. So thank you very much. I think most of the surgeons will be happy to know that most of the medical oncologists that is the main treatment now gradually. And from what we are seeing, even the surgery will be gradually de-escalated for the primary. Yeah.